everyone and welcome back to Mezzomedic. My name is Kitty and I'm an academic junior doctor working in the UK. Today we'll be talking about the Academic Foundation Programme interviews, specifically regarding the Clinical Management Station. This video is aimed at final year medical students who are applying for or have already applied to the Academic Foundation Programme. If you do not know what an AFP is, you can check out this other video on my channel which explains the AFP structure and if you should apply. In this video we'll firstly go over the format of the AFP interview. We will then go through what you can expect from the clinical management station of an AFP interview, including the clinical emergency scenario, ethical questions, and public health awareness. I will be addressing some key topics that you need to know in each of these areas. I will then demonstrate an example of how I would answer a clinical interview question, and finally share my personal top tips in preparing for the AFP clinical station interview, and also what other resources you may find useful. So firstly, let's talk about the format of the Academic Foundation Programme interview overall. This will differ depending on which deanery you have applied for, but mainly they will be split into 3 different stations: the personal CV and career aspirations, clinical management, and academic critical appraisal. Some deaneries may not have a personal question station, and others may negate the academic critical appraisal station if, for example, you're applying for an education or leadership AFP post. The length of the interview will also differ depending on where you apply. Some places will do a 20-minute panel interview comprising of all 3 stations, whilst others will do 3 separate 15-minute OSCE-like stations, if you will. The amount of preparation time you're given will also differ. For this reason, it is really important that you find out what the structure of the interview may be like as early as possible. This information may be available online, by word of mouth from previous year's applicants. Or you can also try and get in contact with the program director of your preferred AFP deanery and see if they can give you any information in advance. So what is the clinical management station? The clinical part of the AFP interview is designed to benchmark and test your clinical knowledge. Since you have to be first and foremost a good doctor before an academic, and you have reduced time for clinical activities in your AFP program. Generally, this station is focused on managing a clinical emergency, and may or may not involve questions with an ethical component or awareness about public health. So let's talk about all of these in turn. So firstly, the clinical scenarios. Most of the time in an AFP interview, these will be clinical emergencies. I'll put up a list of topics that might come up on the screen now, and this is not an exhaustive list, so you should think about any other situations where a patient can present acutely unwell. The best way to learn and prepare for this is probably to learn the Oxford Handbook of Clinical Medicine emergency section at the back, and be able to recite the investigations and management for each of these emergencies by heart. And the thing is, you need to learn these for your medical school finals anyway, so this is actually an opportunity for excellent revision. The key skills you need to demonstrate here are competent skills in assessing an acutely unwell patient, sound clinical reasoning and judgment, starting the appropriate investigations and management for common clinical emergencies, be able to interpret test results, practice evidence-based medicine, and above all, being a safe F1 and knowing when to escalate. In terms of structuring your answer, because you're most likely dealing with an acutely unwell patient, you should always use the A to E approach. Broadly, aim to structure your answer with assessment first, then investigations, then management. Keep in mind that your examiners will most likely be giving you information as you go along, such as when you request for a VBG, they might have some results for you to interpret, so using this structure will allow you to cover all the areas and be prepared for any surprises when they hand you any results. In terms of talking about examination of the patient, practice saying A to E out loud, describing exactly the steps you would take, and aim to finish this in 2 to 3 minutes on your own. The goal here is to be as slick as possible so that you can say A to E without even thinking about it. So in the interview, when you're nervous and your heart is beating 100 miles a minute, you can say all these things without thinking about it and actually buy yourself some time to think about what is wrong with the patient, what is the scenario, what is your diagnosis, and what is your management. Something to keep in mind as well is that unlike in medical school where examiners may be more lenient, in AFP interviews they often don't give you the information that you need unless you have specifically said that you're looking for it. So being really thorough with your A to E is very important so that you don't miss any key bits of information, for example doing a PR in an upper GI bleed patient. When describing investigations that you want to do, you should structure them with bedside tests first, then bloods, then any other imaging and any further tests. You need to be really specific when you describe the investigation you want, so don't say, I would like some bloods, say I would want a full blood count, user needs, LFTs and a clotting and a VBG. Then explain your rationale for ordering the investigation. For example, I would like a chest X-ray to look for consolidation or any signs of heart failure. As we mentioned, throughout your A to E, interviewers are very likely to give you results as you go along, especially for bedside tests that can come back quickly in real life, for example an ECG, blood gas results, and a chest X-ray. so you'll need to be confident when interpreting these test results. It is also a good idea to learn some reference ranges so that you have them in your head, for example in arterial and venous blood gases. Although you often get these ranges in real life, in an interview they might just hand you results without the ranges, and if you don't know them, then you're stuck with interpreting a results that you don't know what they mean. When you have procured sufficient information from your initial list of investigations and your ATE, you should provide a main diagnosis and a list of differentials. If you're unsure what is wrong with the patient, you can always say this out loud, but ensure that you've covered your tracks by being a safe doctor, sending off the appropriate investigations and starting the initial managements that you can do, such as fluid resuscitation. In terms of the management, once you've determined what is wrong with the patient, you need to start some definitive treatment measures. This can range from measures as simple as giving the patient some fluids to preparing them for theatre. Always remember to escalate to a senior if you identify an acutely unwell patient. You can always do this earlier in your ATE if you're concerned, but interviewers are often looking for you to start some simple measures as the F1, so don't end your answer with saying that I will escalate to a senior and not offer any more management. If you do not know the definitive diagnosis here, the key again is to be safe, so starting simple measures like a fluid bolus if their blood pressure is low, or giving them some oxygen if their oxygen sats are low. You would probably also want to escalate earlier to a senior and get them to come review the patient sooner rather than later. Another top tip to remember is that you should always try and incorporate evidence-based medicine in your answers where possible. The easiest way to do this is to remember risk stratifying scores and incorporate them in your answer. For example, the Gray score for patients with an MI, the Wells score for PE and DVTs, and the Glasgow-Blatchford score for patients with an upper GI bleed. If you've read any recent research papers that address management of these patients, you can always mention this in your answer as well. In terms of the ethical component, most AFP clinical interviewers will also tag on a few questions about this at the end of the clinical scenario to test you on your GMC good practice. This may include things like understanding patient capacity and Fraser and Gillick competence. The key principles to remember in any ethical question is patient autonomy, beneficence, non-maleficence, and justice. Make sure to describe these specific terms in your answer as well, so if you're asking the patient whether they understand the decision, make sure you use the word capacity to ensure that you actually score full points for that station. You may also get questions with difficult colleagues and difficult patients, for example, a senior who is refusing to come and review your patient or refusing to admit them. Like an SJT question, the key here is to demonstrate your communication skills and also knowing how, when, and who to escalate to. And lastly, you might also get asked some public health questions. These are less likely to come up, but you should also have an awareness of them. Most likely, this might come up in the context of discharging a patient back to community and arranging any follow-up plans. Possible topics that might come up include advanced care planning, counselling for smoking cessation, and follow-up for patients with mental health concerns. Okay, so from the history the patient gave me, I'm concerned that he's acutely unwell, therefore I'm going to assess this patient in an ATE fashion. I would like to ask the nurses at this point to get a full set of observations for me. And firstly, I would like to check if the patient's airway is patent and if he's talking to me normally. Okay, then I would move on to breathing, so I would check his respiratory rate and his oxygen saturations, which are both okay at the moment, so I don't need to give him any oxygen. I would like to auscultate his chest and percuss for any abnormalities. Okay, so that's fine. Moving on to circulation, I want to check his heart rate, and is the heart rate regular or irregular? And I would also like to check the cab refill time. Okay, so 3 seconds, that's a bit slow, and listening to the heart sounds for any abnormalities or any murmurs. Okay, so he's got a harsh ejection systolic murmur, which is most likely linked to the aortic stenosis as we know from his history. I'm slightly concerned over the long CRT, the tachycardia, and also the low blood pressure that might indicate that this patient is volume depleted, especially in context of melena. I would therefore want to insert 2 wide-bore cannulas and start him on a 500 stat bolus of crystalloid-like Hartmann's. I would also want to take some bloods at this point, including a full blood count, Usenis, LFTs, and a clotting in context of the bleed, as well as a VBG. I would also like a 12-lead ECG for the patient given his tachycardia and history of AF as well. And then I would want to complete my ATE, so in D, what's his GCS, and what's his temperature and his glucose. Okay, then I want to expose and examine the rest of it, including the abdomen, looking for any tenderness or any discomfort anywhere. And given the history of potential melena, I would also want to do a PR on this patient. Okay, so that's my ATE. I would want to reassess him after the fluids have gone through. Other investigations I would consider is potentially an erect chest x-ray to rule out any perforation given the history of a upper GI bleed, and also potentially a CT abdomen with contrast to look for any particular areas of bleeding. So looking at the VBG, I can see that the patient is acidotic with a low pH. He's got a low hemoglobin of 56 and a higher urea, which suggests that he's dehydrated and has had a bleed. This patient is in metabolic acidosis, and I'm quite concerned about him at this point, so I would like to call my senior and inform him that there's an unwell patient with a possible upper GI bleed, likely because of a peptic ulcer, with risk factors in history including aspirin use and being on a DOAC. He's also got a history of severe aortic stenosis, so I would be thinking about Hayday syndrome contributing in this case. In terms of managing this patient, I've already given him some fluids and called my senior. I would like to give a IV PPI 40mg of omeprazole stat in context of the upper GI bleed. I would like to take a group and save and cross-match some blood so that this patient can have a transfusion in context of his low HB. I would stop his aspirin and rivaroxaban in context of the upper GI bleed and consider other medicine reconciliation as well. This patient will need an OGD as a diagnostic and or therapeutic treatment, so he will need to be made nil by mouth and be put on regular fluids. I would also use the Glasgow Blatchford score to risk stratify this patient. So in terms of my personal top tip, I would say that the main thing you need to do is just to practice saying ATE over and over and over. It can feel awkward to start at first with not so much as a sim man in your sight and no visual cues at all as to what you should do. But with practice, you'll be able to get used to this and be really slick with your ATE. The best way to do this is probably come up with a list of scenarios that you think could potentially come up, and then practice saying the ATE in response to the scenario and how you would manage the patient in this case. You can practice with your peers who are also applying to the AFP program, practice with your other medical friends as an OSCE practice, or even just saying it out loud to yourself in front of a mirror or recording yourself saying it and checking that you appear as a confident candidate. In terms of resources that you might find useful, we've already discussed the Oxford Handbook of Clinical Medicine and the emergency section at the back, which is really good for learning all of this. And there's also this medical interviews book. This is a book that most medics will get in their lifetime. It covers interview skills, not just in AFP, but in core training and specialty training and registrar interviews as well. So it's a really well spent £25 in my opinion. In here, this book covers common questions that come up in interviews and provides structured answers to each of these questions. Aside from clinical answers, this book is also great for any personal questions about your CV that might come up, as well as ethical scenarios that you should be aware of. So in summary, the clinical component of the AFP interview will include management of a clinical emergency, ethical questions, and public health awareness. The key is to demonstrate good clinical judgment and practicing safely as an F1. Learn the common clinical emergencies that might crop up and the investigations and management, then practice, practice, and practice. So that wraps up this video. Thank you so much for watching, and I hope you found that useful in preparing for your AFP interviews. I'll soon be releasing other videos on the academic critical appraisal part of the AFP interview and how to prepare for that, as well as the personal station. Make sure you give this video a like and subscribe to the channel so that you can get notified when a new video comes out. That's it for now, and see you next time.